webinar, Implementing Harm Reduction Strategies in Your Health Center. My name is Adrienne Bridenstine. I am the Health Policy Organizer for the National Healthcare for the Homeless Council. The National Healthcare for the Homeless Council is very pleased to be working with the National Alliance to End Homelessness on this really important educational opportunity, and we thank you all for participating this afternoon. Before we get started with the webinar, I just want to go over a few little details. Wanted to remind everyone that you are eligible to receive continuing education credits for participation in this webinar. To receive this credit, you should have already have completed a pre-test. Then following the webinar, you will receive a post-test. Upon completion of this test, you will receive your continuing education certificate. I believe you'll receive it in the mail. Also, to remind you that we will be taking questions at the end of the webinar, but you can submit your questions throughout the webinar as they come to you. There should be a little question button that you can click on. You type in your question and then submit it. We'll get it after our panelists are done speaking. So without further ado, let's get started. Today's speakers have a really unique set of skills and knowledge on harm reduction strategies. These expert panelists all work in healthcare for the homeless projects across the country and have effectively used a range of harm reduction techniques to engage people experiencing homelessness into primary care, behavioral health care, and other stabilizing services, including housing. Our first speaker this afternoon will be Ed Stellan. Ed works in Chicago, Illinois at the Heartland Health Outreach. He will be going over what harm reduction is and what harm reduction isn't. Following Ed's presentation, we will go to Jan Coughlin. Jan is the Director of Mental Health and Social Work at Healthcare for the Homeless in Baltimore, Maryland, and she will be providing us some best practices from a social worker's perspective. After Jan, we'll be going to Miriam Karamoy, I'm sorry, I may have mispronounced your name, who is the Medical Director at Albuquerque Healthcare for the Homeless, and she'll be providing us a medical perspective. So without further ado, Ed, please get us started.
Thank you. And as Adrienne said, my name's Ed Stellan from Chicago, and I'm just trying to advance my slide here. Oops. Okay, there we go. Here is my contact information. And I just want to let people know I've worked at Heartland Health Outreach for about 17 years, and really kind of slowly, early on, but kind of slowly in an organic way, came to embrace harm reduction as a way to engage people who are homeless, especially people with mental illness and substance use disorders, into services. And at HHO, we have a variety of mental health outreach, outpatient, and residential services for folks. So my goal today is to really just focus on definitions and really work toward a common understanding of harm reduction. At Heartland, we look at harm reduction as an approach that can be used with a variety of folks who engaged in high-risk behaviors. Certainly substance use is the one that comes to mind, but there are other risky behaviors around sex and violent relationships and things like that. So here we have a definition of harm reduction that we use here at Heartland that refers to people marginalized by high-risk behaviors having the right to access for a continuum of service options and strategies that include outcomes such as reduced harm or abstinence and enhanced quality of life. And one of the essential features is that we recognize that people engaged in these kind of behaviors are very resilient. They're survivors. They've got a lot of skills. And another piece to this is that we really work hard toward reducing the stigma associated with folks who engage in such behaviors. The Harm Reduction Coalition out of New York describes harm reduction as a set of practical strategies that reduce the negative consequences of drug use, incorporating a spectrum of strategies from safer use to managed use to abstinence. Looking at that sentence, I think that there are a couple key concepts in here that are really important. One is that harm reduction really is a spectrum of strategies. A lot of times harm reduction is seen as anti-abstinence or an alternative to abstinence, when indeed abstinence from high-risk behavior is the most effective way to reduce harms associated with that behavior. But importantly, harm reduction and the practice of harm reduction is a process whereby we meet people where they're at, and we recognize their willingness and their ability to engage and change as they define that. And we try to So, as I said before, we recognize harm reduction as a set of strategies that can be applied to folks who engage in a wide range of high-risk behaviors. However, and harm reduction is also something that we do all the time. Safer sex is an example of harm reduction, abstinence being the most effective way to avoid a sexually transmitted infection, for instance, but that short of abstinence, we recognize an array of different strategies, from very high risk to less risk to, of course, no risk. Safer driving is an example. Driving is not a safe way of getting to and from places. It's not safe on a personal level and certainly environmentally. And so we've taken steps short of abstaining from driving to minimize some of the risks and dangers of driving. Safer drug use is very similar, recognizing that abstinence is a great way, the most effective way to avoid the harms associated with drug use. Along the way, we do know that there are behavior changes that can be made that will help people reduce some of their risks. Okay. And when we talk about safer driving, boy, that makes sense. When we talk about safer sex, well, we might get a little less comfortable talking about sex, but it still is fairly non-controversial. It's when we start to talk about harm reduction and drug use that a lot of folks, especially in the United States, become uncomfortable. And we could speak at length about why this is, but certainly there's cultural and social factors, just that in our country we've had a long and uneasy history of our acceptance and attitudes around drug and alcohol use. Certainly politics and not science tends to be the basis for our drug policy. And then there's also a lot of mythology that affects our perception of why some drugs are horrific and others are not so bad. We just have to recognize that it's not all based on science or reason. So I hinted at this before, but I think it's really an important point. It's just that harm reduction and abstinence are completely congruent goals. But harm reduction really allows us to expand this alliance with people. And it gives us really a language and a set of tools and strategies to intervene with folks prior to their being ready to contemplate or engage in abstinence-based strategies. And the other thing is that harm reduction strategies are used any time in the process of change. So we've got some people who quit drinking and quit smoking crack, but they continue their nicotine dependence. And we recognize that they're very successful in quitting 2 drugs while they can maintain their dependence on the third. Were we to require abstinence from all 3, that may then make it difficult to engage in abstinence from any one. So some of the basic principles is just that we recognize and accept that each user is going to make the decision to use or not to use. So we take a very pragmatic approach to this. We treat folks with dignity, and that's especially important when we're talking about drug users. These are individuals who are often unlikely to share with us what they're doing, the nature of some of their behaviors, and for good reasons, because they've been judged, they've been marginalized because of their drug use, and so we really have to engage them in a very normalizing kind of way. At the same time, we expect folks to take responsibility for their behavior, and we recognize that there's natural consequences for all choices. harm reduction programs really make room for consumers to have a voice in the way its services are designed and delivered. We focus on reducing harm, not necessarily consumption. Certainly if the individual participant wants to reduce consumption, then of course we embrace that as our goal. And we avoid predefined outcomes. The services are effective when our program participants say that they feel that they're making progress on the things that they care about and are important to us. So harm reduction is either for or against drug use. It's not a tacit consent to use drugs. And just backing up in terms of neither for or against, the important piece to that is taking a very non-judgmental approach, recognizing that people are going to make this decision, and the extent to which we can withhold or manage our beliefs and our judgments about drug use and drug users outside of that relationship is the extent to which we can have a real open and hopefully provide the environment for a real honest conversation. It's definitely not don't ask, don't tell. With harm, that's actually pretty much harm promotion. We want to encourage people to talk about their high-risk behaviors. We want to normalize that discussion in the way we assess people. We want to ask if people are using drugs, what they're using, how they're using it, why and when and with whom. We want to know as much as possible about their drug use. And with harm reduction, we're really focusing on client-centered service provision. We're really not focusing necessarily on policy. It's not anything goes. We run several housing programs here at Heartland Health Outreach, and we try to be very good neighbors, and we work really closely with individuals on a very personal basis, ensuring people understand that high or not, using or not, all of us are responsible for our actions, and the consequences for those actions are natural, and we will have to bear those. And it's not anti-abstinence. And keeping an eye on my time, and I know that some of these next few slides will be covered by our other speakers. So I did want to just leave us with a few helpful websites. The Harm Reduction Coalition is the United States leading organization in promoting harm reduction. There's also the International Harm Reduction Association. The Harm Reduction Therapy Center out of the Bay Area is interesting, as they've taken harm reduction approaches and applied them specifically to individual and group counseling or therapy. And then finally, the Harm Reduction Journal is a great resource on evidence-based, more empirical studies that focus on harm reduction interventions. So with that, I will turn it over to our next speaker.
Okay. Yes, I'm Jan Coughlin, and I'm from the Baltimore Project, the Baltimore Healthcare for the Homeless Project. I, too, have been here for 17 years. And I can't say I was slow to come to harm reduction. I was actually hungry for it, having failed with clients in a lot of ways in terms of setting bars that were too high for them. I used to really get frustrated with, let's say, detox programs who would not allow my clients to come back in because they were just been there, or they were assessed as just wanting a bed. And I thought, look at all the opportunities you're missing out on. It was actually the words harm reduction gave me a way to talk about that. My presentation is more about organizational considerations, not as much about social work practice, just to clarify maybe a slight difference in what Adrian had said my presentation was about. Although it's not divorced from social work, that is a big part of
of how I incorporate all of this organizationally and individually. I want to start with some of the background thinking. For my presentation, I think that organizations need to consider harm reduction as an approach because when you don't consider it, again, I think you miss the boat with a lot of clients. Certainly not all of them, but in homeless health care, I would say perhaps the majority of them. And I also think, too, as we're thinking about integrating this different paradigm, that it's helpful to view this as countercultural. And that means that helping staff incorporate this new way of thinking, you have to take a long view. It's not going to happen overnight. So I think you start with, what do effective helpers need to know? I think they need to know that behavior change is difficult and that you don't need to be in a rush to do this. The clients want change, and that's not necessarily the change that you want to see. So hearing what change a client wants is a very important part to being an effective helper. And last but not least, the relationship is the most important thing you can have. As long as there's a relationship, there is a chance for change. I'm going to actually gloss over this slide a bit. This talks a little bit about why behavior change is difficult. That's not the thrust of this presentation. Getting on to what works, addressing basic needs, beginning where the client is, Ed already mentioned that, relationship building, putting that first, remembering who the expert is on the problem, and also whose problem it is. I find that when you're not working from a harm reduction angle, often you're trying to fix the client's problem or take it on for yourself. I think that's an area a lot of clinicians struggle with. Now here's where language is funny. I have used this developing an anything goes attitude towards the client, and that isn't at all to contradict Ed's point about what harm reduction isn't. This is my way of saying being non-judgmental, because I'm trying to say what most people think of, in my experience, as being non-judgmental doesn't go as far as it does. I think there's always room for disagreement. So I use that a little bit to be somewhat provocative, that if you think you've got an anything goes attitude, you might find, I'm hoping you're opening your mind up to thinking more about that. And I will talk about where that breaks down a little bit later. It also, exploring options rather than prescribing. If you tell a client what to do rather than get the client to tell himself what to do, it's not as robust. And how you talk a client into making those changes. If you haven't heard of motivational interviewing and aren't using it, I'd like to change your mind about that. I think motivational interviewing skills are absolutely key in this paradigm. I'm not going to spend a lot of time on MI because there's a lot of other ways of getting this information, but one of the things that is great about MI is that there's something you can do to help clients regardless of their readiness to change. So you're not waiting for the client to be ready to change. There are things that you can do in advance of their readiness to change to help them in their readiness to be changed. It can be just a part of the, if you're handing somebody a pair of socks, you can seamlessly integrate motivational approaches into those interventions. And it's not just about substance abuse changing, it's any change, any area where a client might be stuck. And that is a link to a website by the people who developed motivational interviewing. It's not the easiest website I've ever seen, but I also recommend getting the book called Motivational Interviewing. So harm reduction, how does it fit? It's a paradigm shift away from a strict adherence or abstinence model. I think that's how an organization can view it. And it changes the way you relate to your client around treatment planning and incorporates what the client thinks about their treatment plan a lot more than a strict adherence or abstinence model does. You also have a much broader view and menu of solutions. I'm going to skip over this because Ed covered that beautifully. So advantages to a harm reduction approach. Is somebody, okay. It keeps the provider-client relationship alive, and like I said before, the relationship alive, change can happen. It's pragmatic. Ed already pointed that out. There's always something that feels good about what's going on. You're not waiting for the whole Megillah to feel good. Somebody is, mommy stuff? Oh. I think somebody needs to mute their phone. Another advantage is that it eliminates the tension, or at least reduces the tension that exists between providers and the non-compliant client. If you think about setting a bar that the client can't clear, and then the client returns, the client's tense about that interaction, so is the provider. It hurts the relationship. Ed did a great job in talking about who's responsible for the behavior, and a lot of providers tell me they find that liberating. And another advantage is that it focuses on the process and not the outcome. That back to that broader menu of solutions. There's a question: what else can we try? It's really hard to completely run out of possibilities of things to try. So it's not all that. There are some challenges to implementing a harm reduction countercultural strategy. And you might notice I just said focusing on the process and not the outcome was an advantage. It's also a challenge. People can still kind of get hung up in an outcome and get frustrated by feeling like they're not getting anywhere. More importantly, it requires people to be able to hold conflicting ideas and thoughts at the same time. And I think the easiest way to talk about that is drug use is bad, sure, and it's illegal, but it's also good, and people use them for perfectly good reasons. They're conflicting, but they're also both true. Not everyone gets it, and when I say that, I mean more of the clients. I find the clients are as resistant to changing this paradigm as my staff are. And Ed pointed out the not telling the whole story. They've been burned by having to tell that story before. Sometimes the goal is still abstinence, and sometimes clients have a lot of things in their way towards working towards that goal, and they can get frustrated. And there are times it makes some people feel like they're doing the wrong thing. People who've got very strong values around risky behaviors, to talk about them openly, they might have some internal struggle with that. And finally, the staff are not empowered in this paradigm to fire clients they're frustrated with. That's been probably the biggest challenge that we've faced. People get tired of certain kinds of behaviors or certain kinds of countertransference, and they can't just fire the client. So one of the things we've done in our agency the first step we really took in making this paradigm shift was we adopted a harm reduction philosophy. And what that is, it's the principles that for providers that, in our case, we focus on the relationship and not the outcome. Our philosophy talks about behavior change being difficult. We talk a little bit about how the client being responsible for their behavior and how that factors into the treatment. And I also want to point out that in our agency, we were fortunate that we were able to create this philosophy in the upper echelons of the organization and have the adoption of it facilitated all the way down to where everyone had an opportunity to come to learn about it and buy into it. This next slide is about the ingredients that I think you need to consider if you are incorporating this, incorporating harm reduction organizationally. I'm going to talk a little bit touch on each of these ingredients. You really want full administrative buy-in, ideally. It's already, when you're doing anything countercultural like this, you're swimming upstream. If you don't have the top brass of the organization, you need to take an even longer view and hope that you have a little Zen Buddhist in you as well. And it's a good idea if you don't have that administrative support that you begin to model it. You want to look at change as being difficult for an organization as much as it is for clients. You want a solid harm reduction philosophy. That would be the next step. You want to have a document that your staff can refer to. And we have a harm reduction philosophy. Alliance has broader document. Heartland has a broader document that they have adopted. Actually, more recently, our harm reduction philosophy is about 10 years old now. In your organization, you want to have a solid supervisory structure. This change requires a lot of support for your staff because, like I said, it's different. And people notice a difference, and they struggle with these differences in different ways. So ideally, all of your providers have an experienced supervisor that they can meet with regularly. You don't want any supervisor to have so many staff that they can't really make time to talk about some of these things. The more multidisciplinary your work is, the easier this whole thing is. And I've also found in my shop clinical supervision groups to be very helpful. I mean, they can be as simple as a book group, or right now our mental health team takes turns. Each member takes a turn organizing what they're going to teach their peers. We start talking about harm reduction during the interviews. We have found that we really don't want anybody to come on board who finds harm reduction to be really against their value system. That really isn't a good fit. So you really want to talk about harm reduction during the interview. It doesn't matter whether they know about harm reduction or not. Certainly more and more people do have an awareness of harm reduction than they did when we started this whole process. but we're really looking for openness and tolerance in the interview, if not actual buy-in. You want to have ongoing services. It's hard to change a culture. It takes a lot of attention. It's never a one-shot deal. Just trying to teach your staff motivational interviewing. We had an opportunity to work with a local university on training over a 3-month period, and we're still consider it an ongoing process. So back to that anything goes. The trouble anything goes has is sometimes the behaviors are well, I'm going to say unsafe in the clinic, and when they're unsafe, they must be addressed immediately. We don't allow clients to behave in an unsafe manner. So that's imbalanced by having an integrated disciplinary action process. Staff can ask any client to leave for the day. Behavior that's really egregious, we have team meetings scheduled on an emergency basis with a plan for addressing that behavior. You want the leadership in the disciplinary action process to really work towards the goal of using the client's difficult behaviors clinically to help them build on the relationship and working on using these examples clinically rather than punitively. So I think back to a more global way of thinking about this, this is not as daunting as all that. All clinicians take a harm reduction approach at least some of the time. I find that when the countertransference is positive, clinicians are a lot more willing to be harm reductionistic. The trick is to do this on purpose as much of the time as you possibly can. I think it's also really important to be gentle and patient with everyone concerned. And anyone feeling stressed, if it's you, if it's your staff, then that's a sign that you need more support. This here is my contact information, and that is the end of my presentation. Okay, and I'm just going to get my presentation up here.
So I am Dr. Miriam Kamarani. I'm the medical director at Albuquerque Healthcare for the Homeless. And I'm going to try and talk about a perspective on harm reduction from the medical standpoint. My background is I'm boarded in internal medicine and addiction. And in addition to being the medical director at Albuquerque Healthcare for the Homeless, I have a role out of the University of New Mexico running a statewide program to try and increase access to addiction treatment services around our rural state here in New Mexico. To me, it seems that harm reduction is really an essential underlying philosophy for all of medical practice. Although in medicine we've taken very much of a powerful talking to less powerful approach. In fact, only the patient can choose change. And I use the word patient here instead of client, definitely reflecting my medical perspective. But I think that the relationship between the patient and the healthcare provider is absolutely key. And ultimately, the power in that relationship really lies with the patient. The patient is the one who's going to decide whether change is something that he or she wants to pursue or not. As both Ed and Jan have mentioned, the relationship between the two individuals, the provider and the patient is really the only tool that we have for promoting healthy behaviors within the medical context. And respectful communication is really the key to that whole interaction. It's important for me as a healthcare provider to remember that my goal is often very different from the goal of the patient. Certainly at the start of the interaction it is. Hopefully by the end of the interaction we're getting in line and agreeing on some mutual goals that we can pursue. Sometimes we think that we can mandate change. Sometimes we think that that's our job to say, you must stop smoking. You must take this medication every day. It can be a well-meaning but misguided approach to trying to do our best to help people move in the direction of health. In fact, our goal needs to be to help the patient to move toward more healthy behaviors, and the patient is the one who chooses what those behaviors are. And in a nutshell, that's really what harm reduction is within the medical context. Some examples might be that, as Ed mentioned at the beginning, abstinence or radical change are certainly not at odds with the harm reduction philosophy. They're very much part of a harm reduction philosophy, but harm reduction is bigger than that and can embrace behavior change that doesn't go all the way or result in what we may regard as the ultimately desirable healthcare change. So for instance, when I'm working with a patient who is alcohol addicted, a goal that we might agree on that would include a harm reduction approach would be that perhaps she might choose to decrease the amount of alcohol she drinks on an alcohol binge so that she can make better decisions about not driving. So here my goal might be, I think this patient is drinking in real excess and is harming herself. But one of the ways that I see her harming herself is that I know she's driving while intoxicated. The patient may not feel that her drinking is a problem, but she may agree with me that driving while intoxicated is dangerous. And so this is a goal we could agree on that will address both of the concerns we're bringing to the table. For a patient who's tobacco addicted, he might agree to decrease his daily cigarette smoking from 2 packs to 1 pack per day. Certainly not what I would choose if I were the one selecting the goal and the outcome, but one that he and I can agree on together, at least as an initial goal. A third example might be a patient who has diabetes. I might like her to focus on losing weight and getting regular aerobic daily exercise, but she might currently be entirely sedentary and might be very alarmed or intimidated or just put off by those kinds of more absolute goals. And instead, we might be able to come to a compromise around the idea that twice a week, instead of driving to her daughter's house, she'll walk there.
Hi, Miriam, this is Peggy.
Yeah.
I'm sorry to interrupt.
A
couple of people have asked for you to speak up also a little bit.
I'll try. Sorry. I often don't talk loud enough. Okay. So harm reduction is most often talked about in the context of addiction treatment. And in that arena within medical care, I think it's absolutely essential. When healthcare providers are involved in treating addiction, I think it's extremely important to recognize that addiction is a disease that's characterized by relapse. So it's very, very unusual to find an individual who struggled with addiction who stops after one attempt and never uses the substance again. And if we are expecting something different, then we're bound to be frustrated and disappointed. In addition, I think it's, Jan was alluding to her frustration at addiction treatment programs that take a zero-tolerance kind of approach and may not admit a patient back into treatment or may kick them out of treatment if they have any form of relapse. And, my thought about this is that addiction is a chronic disease characterized by relapse, and saying that we won't continue to treat someone who is addicted and has a relapse is similar to saying we won't treat an asthmatic patient who loses control of their asthma, has a low peak flow indicating increased severity of their asthma. So when we're trying to develop treatment goals in conjunction with our patients around issues of addiction, we might develop goals that include decreasing frequency and severity of relapse and using periods of sobriety to acquire skills that can help promote longer-term sobriety. MAT stands for medication-assisted treatment, and this is what used to be called opiate replacement therapy, among other things. And I think it's an important component of harm reduction. It's more and more clear that medications are an essential component of the effective treatment of addiction, and taking an approach that only abstinence and only shunning of all chemicals, whether they're prescribed medications or drugs of abuse, is not a very effective strategy. In my own work, I'm a big proponent of buprenorphine, Suboxone, for the treatment of opiate addiction, and that in and of itself is a very powerful form of harm reduction. In addition, classic harm reduction techniques are also important to incorporate into medical treatment of addiction. So in our program here at Albuquerque Healthcare for the Homeless, everyone who we engage in treatment of addiction, no matter how stable they are, how much they're moving towards successful abstinence, we offer them training in harm reduction techniques around syringe exchange and use of naloxone for overdose death prevention. It can be helpful to think of addiction treatment in terms of a chronic disease management model. This is a model that it's most helpful to implement when someone has a moderate to heavy dependence on an addictive drug and is not prepared to aim for abstinence at the time that we start work with them. They may, in fact, be pre-contemplative. They're not interested in stopping or even significantly curtailing their use of the drug. But typically, if there are so-called medical comorbidities, in other words, problems that are being caused by the drug use, that may drive the patient and the healthcare provider's need to look at the potential for change. So how would you implement a disease management approach, which is really the same as a harm reduction approach? It's most important to start by identifying the patient's concerns and goals, and then looking at where there's overlap between those concerns and goals and my own as a healthcare provider. So we could set mutually agreed upon goals, such as decreasing the number of drinking days per month, decreasing the number of drinks per drinking day, or if a patient is not willing to address the actual drug use itself, it can be very helpful to focus on important supports that can help the patient become more functional, such as increasing the number of social contacts per week to help the patient be less isolated, or focusing on improving housing, finances, social services, etc. If the patient, him or herself, is entirely unwilling to participate in this approach, it can actually be very helpful to engage the patient's family and social support members, if the patient is in agreement with you doing that, to help them decrease behaviors that may actually be promoting the use of drugs or alcohol in their family member, or to get their own support to help the family dynamic be healthier in groups such as Al-Anon. There was an interesting study published in 1999 by Mark Willenbring, who's now the head of NIAAA, the government arm focused on treatment of alcohol addiction. He's a big proponent of the idea of disease management and alcoholism, and he, in the VA setting, he divided patients into usual care groups where they just had their usual interactions with the provider and healthcare team around their alcohol use, and then a specific disease management group that was using the kinds of techniques I just described. And over the course of a couple of years, he found some really significant differences with better outcomes for the disease management group when the patient was really part of the treatment team and setting up the goals for him or herself and deciding what particular things were important to him or her and using the techniques I've described. In addition, they decreased the number of drinks per drinking day and dramatically decreased the number of days since the last drink, indicating, of course, that abstinence did occur even in patients who were initially quite resistant to the whole concept of changing the amount they were drinking. In addition, harm reduction is essential really for negotiating all kinds of behavior change, as has been pointed out by other speakers. And some examples of this within the the rest of medical care might be recognizing that even if the scientifically best treatment from a medical standpoint is, for instance, a drug that must be taken 2 or 3 times a day, if a patient cannot or won't take it that often, it's best to change to a once-a-day drug, recognizing that that in and of itself is a harm reduction approach to get some benefit, even if it's not the scientifically best benefit, when it's something that the patient can actually implement. Another example would be a homeless client may not take a diuretic that I think would be indicated for treatment of high blood pressure because of limited access to bathrooms. And if I think about exploring this issue from the beginning, I'm likely to see less so-called non-compliance or better adherence to a treatment plan, since it's one that the patient and I can agree on. I think that Jan has eloquently made the point of how important motivational interviewing techniques are as tools for harm reduction. And I have some very basic guidelines here about how to approach this. Asking the patient a totally non-judgmental question as the opening to a discussion about smoking or other types of drug use or addiction is very helpful. Asking permission to discuss the issue, and then using change readiness scales and confidence scales, very simply put, saying on a scale from 0 to 10, how open would you say that you are to making a change in your drinking today? And similarly for confidence, how confident are you that if you wanted to stop, you would be able to stop? And then the goal of the rest of the interaction is to help the patient move in the direction of more openness to change and more confidence. And it's always important to choose a mutually agreed upon goal. The final thing I want to mention is an excellent book that was published this last year by Dr. Bill Miller, who is sort of the father of motivational interviewing. It's a paperback, actually it was the paperback that came out this last year. It's called Motivational Interviewing in Healthcare, and it's an excellent publication that really teaches step-by-step in very simple and straightforward ways how to incorporate motivational interviewing techniques into the healthcare setting, and of course that's the flip side of harm reduction, so it's really all about what we've been discussing today. In our own Healthcare for the Homeless program here, we've actually had a discussion group over this last year where we've gone through that book one chapter at a time, and done role plays and worked through the examples, and I think we found it a very rewarding experience. So that's the end of my presentation. Thank you.